Good morning, and thank you for joining us for our 11 a.m. Commonwealth Purchasing Group webinar with McKesson. I'm Phil Dubois, Member Resource Consultant here at Commonwealth Purchasing Group. For those of you that are unfamiliar with our program, CPG is the leading group purchasing organization for community health centers and other nonprofit organizations nationwide. Here at CPG, we negotiate savings and superior service from a portfolio of more than 75 nationally recognized vendors. Our members save over $30 million annually by utilizing our vendor contracts. Today we're excited to have Bill Miller, National Channel Manager at McKesson, lead our discussion on chronic care management, a building block to value-based reimbursement. We'd like to have this webinar be discussion-based, so please feel free to use the raise your hand feature or type a question into the chat section at any time. After the presentation, we plan to stay on for an additional 30 minutes to answer any questions that you may have for Bill or the team and I on the webinar today. Thank you for being here today. Let's jump right into the presentation.
Sounds good. Thanks, Phil. I am Bill Siller. I am the National Channel Manager at McKesson Business Performances. I've been with McKesson for 10 years, and one of the things that I help within McKesson is I'm really looking at the transition from fee-for-service to value-based reimbursement to help our clients with that transition from fee-for-service payment model to our value-based reimbursement payment model. This is what we're going to be digging into today. So first and foremost, we're going to take a quick look at what's happening within the payment model structure and what's happening within healthcare in the United States today, not only from a payment model perspective, but also from our health perspective and our population perspective. Second thing that we'll be going through is the Medicare Chronic Care Management Program, the requirements and the reimbursement incentives of that program. There's been a few changes, and there's been some proposed changes to that program, and we'll quickly discuss those in the third piece. Fourth, we're going to go into how we can evaluate chronic care management for your own organization, just to determine if this is the right fit for you and if you wanted to go into that program. Second to last thing is we'll be talking about how to successfully implement a chronic care management program from a staffing, technology, enrollment, and a billing perspective. And then lastly, we'll be talking about your implementation options that you'll have going forward for a successful chronic care management program. At the very end, we'll take on some questions too, so if you do have some things, just like Phil said, use that raise your hand feature, and we'll get to those at the very end here. To start us off, where we are at within the United States from a healthcare payment model perspective is that there's two curves, if you can think of it in this way. Curve number one represents fee-for-service, and this is the curve that medicine in the United States has always had. We've always had a fee-for-service model since the creation or since our medicine has started within the United States here. Curve two represents value-based reimbursement, and where we're at today within the United States is we are in between these two curves. Organizations have to keep the organization running by having enough fee-for-service patients in the door, while also looking forward and trying to jump on to curve number two at some point and get into that value-based reimbursement world. And as we're going to see in a couple of slides here, that there's a big shift in moving into that value-based reimbursement world within the last 5 years, that we're having organizations that are really having to make sure that they're looking into that future, because that's where a lot of our largest payers are moving into. Our largest payer that we have in the United States being Medicare, they are moving into a value-based reimbursement. It's back last year in 2015, the U.S. Department of Health and Human Services, they were saying that in 2016, this year, that 30% of all Medicare payments were going to be tied to quality or value. So they weren't going to be fee-for-service. There was going to be a goal of 30%, and that was met, and it's actually been exceeded within this year already. They said also that in 2018, that 50% of all Medicare payments are going to be tied to quality or value through alternative payment models. That's what APM stands for. So you can see there's a rather large jump when we're talking about 2 years of time, that's going to jump up 20%, that we're moving from a fee-for-service world to a value-based reimbursement. And what I mean by value-based reimbursement is that your payments would be tied more to a quality as opposed to more of a volume-based fee-for-service world. Also, even the fee-for-service payments are going to have some sort of a tie to quality. 85% of fee-for-service payments are tied to quality today in 2016, and in 2018 that will jump up to 90%. So organizations really have to monitor to make sure that they're going to be aligned with the quality incentives with Medicare, just so that they can keep their doors open and that they can flourish. One thing to really note is if we look at the population perspective, that by 2022, it's predicted that Medicare beneficiaries are expected to compose 58% of provider volumes across the United States. And that's not just for community health centers, that's for the entire United States. That's a huge, huge amount of patients when you think about how much Medicare is going to be taking on in the future. And the reason for that is because of our baby boomers. And this gets into that population that we're looking at. Today within the United States, there's 55.3 Medicare beneficiaries that are covered, and that was covered in 2015. By 2030, it's predicted that that number is going to increase to 80 million people. So you're having a huge increase of people moving into Medicare coverage within the next few years. For about the last 8 years, there's been about 10,000 new Medicare recipients every day because of that baby boomer population. A couple of my coworkers call it the silver tsunami, where we're having this huge bubble of population moving into that Medicare coverage. So it's really increasing, and that is why we have that 58% of provider volumes by 2022. One of the things that we should also mention is that back in 2010, Medicare took a study and they saw the writing on the wall. They saw that there was going to be this big burst of patients that were going to start coming in, and they really had to look at where their spending was going. So they found that 14% of all their Medicare beneficiaries had 6 or more chronic conditions. So that 14% represents the sickest of the 6. They have multiple items that are chronic major problems that are going on with them. That 14% accounted for 46% of all Medicare spending in 2010. So if you think about that, that 14% is a rather small slice of the pie, but that accounted for a huge amount of spending in 2010. What Medicare wanted to do is they really wanted to look at that population and really try to prevent them from going into the hospital or having their conditions worsen so that it's going to be a higher cost for Medicare spending. When they took a look at it, they found that more than 2/3 of that 55 million that we had talked about had 2 or more chronic conditions. So it's a rather large portion of that population that has 2 or more chronic conditions. So really trying to go after that population with multiple chronic conditions, because that is where the cost is most associated. If we look at chronic care management, this was a program that was rolled out last year, and that it was not rolled out to community health centers and FQHCs and RHCs. It was only rolled out to private entities. This year, beginning of 2016, community health centers, FQHCs, and regional health centers could roll out the program and could receive the benefits from chronic care management. The goal of the program is to raise patients' outcomes, so to stabilize their health that they have, to make sure that they're not going to the emergency rooms, that their health isn't deteriorating, that they are more of a preventative stance when it comes to these patients with multiple chronic conditions. And the other thing from a Medicare perspective is also to save costs. Whenever you look at things from a preventative stance as opposed to a treatment stance, you're looking to save costs. Pennies on the dollar is really what they're trying to do with this program. So those are the 2 goals. Now, how are they going to achieve these goals, you might be asking? So they're going to really look at that patient population with 2 or more chronic conditions. And like we mentioned before on the previous slide, that's 2/3 of that Medicare population has that 2 or more chronic conditions. So that population that has the multiple chronic conditions, we want to be able to have some sort of a touch with that patient outside of your organization, outside of the 4 walls of the exam room. What we want to do is be able to talk to that patient for 20 minutes a month to ensure that that patient understands what's going on with their health care, so that they're going to feel more empowered, more compliant, and that their health is going to improve outside of the exam room is really the idea of it. So under CPT code 99490, Medicare is paying for non-face-to-face care coordination services with those beneficiaries that have 2 or more chronic conditions. Who is going to perform that? So if we look to that box in the lower left-hand corner, these services are most likely going to be fulfilled by the clinical staff. So that would be a nurse that would be calling the patient, a physician. We have some organizations that have pharmacists that are calling the patient. We have some organizations that have medical assistants that are calling patients. So it has to be a clinical staff member. This would be billed out underneath the provider. One of the other things I should mention is that you can also have a third party perform these services for your patients. If we look to the financial reimbursement for this, what do organizations gain from a financial perspective by providing these services? And that's just from a Medicare perspective. We're going to talk about what are some of the other benefits of having this program that are not related to financial portions, but it's a $40 reimbursement, and that's per member per month. So for any patient that you're able to have that 20 minutes or more conversation with, you're able to bill out that $40 to Medicare and receive the reimbursement for that. So that's a quick rundown of chronic care management. If we take a quick poll question here, are you currently billing for non-face-to-face chronic care management under CPT code 99490? So we wanted to take a quick look to see if anybody on the phone had been going through and had been had their own program running, just to see if how ahead of the game that you are. Now, remember that regional health centers, FQHCs, they were just available to roll out this program at the beginning of 2016. So it's only been about 10 months that organizations have had to be able to start this program. So want to do a quick poll question there. So as you're typing in those poll questions, what we'll do here is we will we'll move on and we'll get into that, and we'll show those poll results here in just a second. Getting into some of the more details on chronic care management. So we have a good overview of what the program is looking to do and how it's rolled out, but let's dig into some of the details. So first, from a patient perspective, who are the patients that are able to qualify for this program? It's the patients that have those 2 or more chronic conditions. They have to have traditional Medicare. We're also seeing in some states that certain states are also opening up their Medicaid patients for this. So I would definitely take a look at your Medicaid population to see if they have multiple chronic conditions, because they might be able to get some sort of a benefit from this. One of the things that we should also mention is that Medicare is always the trendsetter when it comes to programs and how things are going to be paid out. And a lot of the states are looking at Medicare right now to see the benefits from this program so that they can potentially roll out this program in the future. So patients must have traditional Medicare. Patients also must provide their consent. So they have to fill out a consent form if they want to sign up for this program. And the reason for that is because patients have a little bit of skin in the game when it comes to chronic care management. The Medicare wants patients to pay a copay of 20% every month. If the patient has a secondary, or if the patient has Medicaid as their secondary, that's going to get covered by that secondary insurance. So I wouldn't worry about that if your patient has a secondary. It's only those patients that have traditional Medicare as their primary and don't have a secondary are the ones that would have to pay the $8 copay a month. Last thing is that patients can only participate in one provider's program at a time. Medicare wants to have one provider that's managing this patient because they have all these chronic conditions. They really want to have one medication list. They want to have one care plan so that everything is going through that one provider, and that one provider is the central nervous system of it all. From a provider perspective or from an organization perspective, first and foremost, all of these records must be maintained in a certified EHR technology, and certified being meaningful use certified EHR technology. Second piece, the provider or the clinical staff must explain the scope of chronic care management services to the patient, and also how the patient can revoke those services. So at any time if that patient is unhappy with the services or they don't want to pay the $8 copay, they can get out of that by revoking that through the phone call, through email, through whatever method that they need to be able to do. Third piece here is that patients have to come into the office in order to enroll into this program. Medicare wants the patient to be seen for an office visit, and that would be like a physical exam. So an annual well visit, initial Medicare visit, or a 99212 to a 99215. So any of those office visits, which are the majority of office visits that a patient would be coming in for, would be able to qualify that patient for this visit or for the enrollment. And then if the patient wants to enroll in the program, they would sign the consent form and they would be good to go. Last piece is that organizations must provide an on-call service or 24/7 urgent care with access to the patient's electronic medical record. The idea on this is if the patient has a concern that they need to go to the hospital, that they're able to get a hold of somebody and that person is able to direct them that they should just make an appointment in the morning, or maybe it's something that they should go to the ER for. So that you have to have on-call services to perform these chronic care management services. Let's talk about some of the changes to chronic care management. So we've gone through the program pretty detailed so that you have a good idea of the reimbursement, what you need to do to implement the program from a high level. And now we'll talk about some of the changes that have been made to chronic care management and some of the proposed changes. In July 2016, CMS decided to relax two of the requirements for this program. That being, providers had to have 24/7 access to their patients' records. So this doesn't limit that providers have to be on call or anything like that. It's just that on-call physician does not need to have immediate access to that patient's records. So that's what that is referred to. The second piece is certified EHRs being used to share clinical care summaries for those patients. One of the big things when this program was first rolled out was that we wanted to have transfers of the records between all of the providers that patient was seeing. That no longer is being required. So it's not certified records are having to be shared. Only the billing providers are required to share records with other providers in a timely manner, and that can be in many different manners. Moving on to some of the other changes that we have, and these are proposed changes, so I really want to underline that these are proposed. These are not set in stone yet. We should find out soon if these are going to come true within 2017. First is they're going to try to simplify chronic care management. The first thing is they're going to not require the consent form anymore. If the patient wants to enroll in the program, all they would need to do is that the provider would need to document that in the record. And again, this is not set in stone yet, so this would take place in 2017 if these proposed changes were to go through. But at this point, the patient still needs to fill out the consent form. Also, the initiating visit is relaxed. So new patients or established patients are the only ones, and the established patients that have not been seen in 12 months are the only ones that would need to come in for a visit to sign up for this. So they're really trying to open up the program so that it can hit the mass quantities of Medicare patients. And then the last piece is that there's relaxed documentation, care plan, the access, and the format, really trying to open it up to organizations so that it's not as strict on that piece of it as well, so that they can really start hitting all of these different population bases and all these different organizations. So number one is simplification of chronic care management. The second thing that is proposed as a change to chronic care management is that there's new billable codes. The other thing that's been proposed is that there's going to be a higher rate that you would be able to receive a reimbursement from chronic care management in 2017. So really trying to push this program and really make sure that organizations are getting a financial benefit from doing this. Also, there would be billable codes for patients that have behavioral health issues, and there would be 3 added codes that providers could bill out with those behavioral health. So if you have a patient that has some sort of behavioral health problem and you're able to counsel them on the phone and connect them with a mental health professional with the PCP, there's some added incentive from a financial perspective there. Also, there's proposed codes for cognition and functional assessments. That's great for those patients that have that dementia and Alzheimer's, that you're able to monitor those patients and receive some sort of a financial incentive by doing this over the phone. Letter C is care plan development. One of the bedrocks of this program is creating a care plan for the patient. It's documenting all of those chronic conditions and making sure that those chronic conditions have goals and that we're monitoring all of those things. If you have a patient that has 6 or more chronic conditions, it takes a long time to create that care plan, and that is why there is now a care plan development code, so that providers and organizations can get some sort of a reimbursement for not only being on the phone with the patient, but doing the work outside of that phone call. D is complex chronic care management services. So if that patient has a lot of issues that are on the phone, this is how you can get a higher reimbursement for a patient that has 10 chronic conditions as opposed to a patient that just has the 2 chronic conditions. There's going to be a different amount of complexity that you're going to discuss with those 2 patients based on that, and there's going to be different rates based off of the complexity. So not just the $40 reimbursement, you might be able to receive a higher reimbursement based on the patient's complexity and the amount of work that you're putting in. But right now, it's just that $40 reimbursement when we're talking about any patient. Letter E is the prolonged evaluation and E&M services. So if you have a patient that's coming in and that's a patient that's tied to chronic care management, and the provider and the nurses are having to do a lot of work on that chart prior to that patient going into the exam room, you're able to charge some time for that prolonged evaluation. So a lot of great changes that look like they're coming into chronic care management just to open it up and to give a little bit more of a financial incentive for organizations to provide these great services. Now let's talk about if chronic care management is a good fit for your organization. And even if it's not a great fit for your organization, it's a great thing to know and understand, because as we can see within healthcare, that's where we're moving. We're moving to a preventative stance where we're trying to communicate with patients outside of the office and make sure that their health does not deteriorate, that they're able to have some sort of a stabilized healthcare. The advantages to participating in this program in chronic care management is, number one, higher quality of care. We've seen that in the short amount of time that this program has been out there. Since the beginning of 2015, we've seen that patients with those multiple chronic conditions are going to the hospital far less. They're also improving overall. And number one, they actually feel better themselves. When they've been surveyed, over 50% of them say that they have more power over their own health care and that they feel better about things. So patients are happier, patients are having a higher quality of care. They're not going to the ER as much, which is great. You also have a new revenue stream. When you're talking about chronic care management, it's a brand new revenue stream that you're able to bring into your organization, but that also helps you with things like annual well visits. That gives you an incentive to get that patient in the door and to have them seen for that well visit. this is a way that you can get those patients into the office every year and to help that revenue stream. We call it the paid-for Petri dish, but this is really just helping you get into chronic care get into value-based reimbursement, where you're able to go into that area where you're focusing on prevention and you're focusing in on value and quality as opposed to the volume. Return on investment for outreach programs is really hard to quantify. With this program, it's very easy because you can see all the patients that you're touching. You can see how many times that they've had an episode, or if their care and their cost is going up, or if it's decreasing. You can really do some nice metrics on those types of things from this outreach program. And it's very easy to do because you're staying in a fee-for-service world, but you're dabbling in that value-based reimbursement world. Also, the increase in primary care physician volume is something that we've seen our own clients have an uptick in. They're not losing patients to the ERs. They're having those patients come back into their offices instead of going in there. So when a patient might think that, oh, I really have to go to the ER now, when they talk to the nurse, they might find, oh, this isn't something that is that critical. I can come into the office with it as opposed to going into the ER. So the PCP volume does go up with this program. So there are advantages other than just the financial reimbursement. Some of the disadvantages to participating. So if we're going to talk about the good, we also have to talk about the bad. So first is the devoted staff. The amount of time that you have, or the amount of people that you have that are devoted to this program is pretty large. When you're talking about having a nurse, pharmacist, medical assistant on the phone with that patient, that's a big investment when you're looking at that. Technology needed. Having that documentation, having some sort of a chronic care management module that can monitor how long that you've been on the phone with that patient. It's not required, but it's definitely something that is recommended so that you can track how long you've been on with that patient and you're able to template out those care plans. That's another investment that needs to take place. Also, if you want to make those care plans available to the patient down the road, that's another thing that would need to be made available to the patient. Billing challenges. If you feel that collecting copays from patients is going to be a challenge, then that might be something that you might want to steer away from. But actually the billing is pretty straightforward. It's one CPT code at this point, and the ICD-10 codes are reused. So from a billing perspective, it's very simple. The only big problem would be collecting copays, and from a regional health center, FQHC based, I don't know if you're going to be collecting that many copays for some of these patients just because some of those will be waived. Slow ramp up. One of the big things that we found is that when you flip the switch and you go live with chronic care management, you still have to wait for those patients to come in the door and sign up for the program. So there is a ramp up period where it takes before you're going full speed with this program. And also the need for a strong clinical process. The communication between the nurse, the physician, all those types of things really need to be strong because you're having that extra resource that is on that phone with that patient and really needing to have that strong documentation and the strong communication so that that patient is not left in the balance. Let's talk about what your patient population should look like if you wanted to really be a solid candidate for the program. So first and foremost, I would take a look at your Medicare patients first, and this is your traditional Medicare patients. I don't think any of you might have that many Medicare Advantage. I might be wrong, but if Medicare Advantage plans are not paying on this, it's regional Medicare Advantage plans are having some success with paying on this. So it's traditional Medicare is what the program was based on, was what it was created for. Some Medicare Advantage are paying for this, but you would definitely want to talk to those local plans to see if they're participating in this program or not. Second piece is if Medicaid is paying in your state for these services. We found that some are paying and that others are not. In the states that they are paying, it's a much lower rate than the $40 reimbursement, and that's because the copay is waived. So that that rate would go down to about $36, and I've seen it in some states to $32. So double check, see if your state is paying for chronic care management services, and then that's a good way to be able to quantify, and also see what the reimbursement is too, because that's a good way to quantify if the program is going to be a good fit for you. And then we mentioned before that Medicare Advantage is plan to plan locally. So that's another thing to investigate, is to see how many of those patients that you have and how you can go through that. We'll talk about the numbers and how those kind of fit in with this, and how to determine per provider how many patients that you should have if you wanted to move forward with this chronic care management program. We talked about previously that when we look at the Medicare patient population, that 66%, 2/3 of them had that 2 or more chronic conditions. So if we look at it from a whole, you had 2/3 that fit into that bucket. The average enrollment rate that we're seeing is about 25%, and then some organizations are actually knocking that 25% out of the park, and it's about 40%. So I would say 25 to 40%. We like to use the conservative on this slide. So if you have one provider that manages about 300 Medicare patients, you would have 200 of those patients would be eligible, and then the potential enrollment would be about 50 patients that we would forecast would be enrolled in this program. So that would be over the course of a year that you would be able to get 50 patients for that one provider that would have 300 Medicare patients signed up for the program. It's the idea of how you would be able to look at that. And this is based off of just some of the national averages that we've seen once the program's been rolled out. Again, if you have that one provider, and remember that would be with the 50 patients that are signed up for chronic care management, the reimbursement for community health centers, FQHCs, regional health centers, is $40.82. If you are not an FQHC or a regional health center, you would look at the Medicare fee schedule, and it's regional how you would be reimbursed for the program. So just understand that you might not have that $40.82 reimbursement if you're not an FQHC and regional health center. That's going to be local to what your reimbursement is. But the national reimbursement for FQHCs and RHCs is $40.82. If we take that $40.82 and we have that over 50 patients, the estimated revenue per provider would be about $25,000. So $24,492 is what that 50 patients would be able to generate from a revenue perspective over 1 year. And again, we talked about all the other benefits. Financial benefits is being one thing that you can really quantify quickly, but the stickiness to that provider and being able to have their health improve is the biggest thing. The quality of the healthcare improving is the largest thing that you're going to see from this program. So we've talked about how you can crunch the numbers, how you can see if you're going to have enough patients that are going to make this model work. We normally say 300 Medicare patients per provider is a really good point that you want to stick to be able to get that 50 patients, because that 50 patients per enrolled provider are the ones that you really want to go after. Now let's talk about how you can successfully implement the program, and I'll try to go through this rather quickly since I know that we're kind of getting up against time here. So we talked about how these who can provide these services and who's the billing provider. So physicians can bill these services, and then also advanced practice providers. The providers that can execute these services are nurses, medical technicians, pharmacists, and other credentialed clinical staff. So that just gives you an idea from who can perform these services and who can bill for these services. Moving on, you might be wondering through this whole presentation, what is happening on that phone call? So when a patient is being called, what are they talking about with that nurse? So for that 20 minutes of that monthly non-face-to-face time, the bedrock of that conversation is that care plan. And we mentioned before, that's just monitoring their chronic conditions, setting goals, and seeing how they're doing compared to those goals. Another large piece is the medication reconciliation. We're trying to gather all of the medications from all of the different providers that this patient is seeing and trying to get that onto one list so that the patient doesn't have any complications with their medication. Also, transitions of care. Big piece is when that patient goes to an emergency room, there's a huge percentage that they go right back into that emergency room. The transition of care gets them out of that setting of care and tries to get them safely out of it and get them back into their normal residence. And then care coordination between providers. This is making appointments for that patient, whether that's an annual well visit back with their PCP or making an appointment with a specialist that that patient needs. When care coordination services are provided to a patient, they are much more likely to go and have that appointment created for that other specialist. And that's the access to care, which is the big driver of this program. It's one of the big benefits for patients is the care coordination. Not only are they having their health improved, but they're also had their life made easier because they have somebody making appointments for them and exchanging records too, so that those records are coming back into the chronic care management providers' records there. Moving on from the staffing expectation, we've talked about all the different clinical components with the program, but there's also an enrollment piece. That enrollment piece shouldn't be overlooked because if you don't have any patients, then you're not going to really be doing anything with a live program. So the enrollment piece is also one where you need to be able to have a process that's under 2 minutes to be able to introduce that program and get that patient signed up. Talked about the clinical phone calls. About one clinical resource for every 250 patients is what we've seen has been the average. One of the things I should mention is that first chronic care management phone call is pretty big. We've seen it that it averages over 60 minutes because there's so many chronic conditions, so many medications, a lot of things are having to be discussed in that first phone call, so it does take, it's a resource hog. Care coordination is another one where you'd have one resource that would be taking on about 250 patients. And then the billing is very straightforward. You're just having to collect that 20% coinsurance if that's something that your patient population is going to be on the hook for. From a technology perspective, it's very easy with the system. The only thing that you would really need to zero in on is those care plans. Do you have a system that can document those care plans, have some sort of a template for it, and then also document the time when it comes to these items? So that be that last piece, the conditions, the goals, the barriers, and the treatments is what you have to have documented on that care plan, and also the time that you spent with the patient, those being the big things that you would need to have from a top documentation perspective. And it's recommended that you'd have some sort of a chronic care management module. It's not a necessity, but it's definitely recommended. Here's a little bit about the enrollments, but it is a team effort. That's one of the things that organizations usually put a lot of effort into the clinical piece of it, and they don't think about the enrollment piece of it. And unfortunately, if you're putting all your money into the clinical piece, then you're not going to have any patients to see in the clinical side because you're not going to have any patients enrolled. But it is a big team effort. Having that front desk, the medical assistants, having the providers being able to provide all those the questions for the patients, the goal being trying to do this under 2 minutes with introducing the program, talking to them about it, and then also just going through the different requirements for the enrollment. That is a big piece that you'd want to have for this program. And then the billing, we talked about that. It's very straightforward with the codes, and also collecting that coinsurance might not be that big of a problem based off of some of the patient populations that you might have. So let's go into evaluating your implementation options. This is our last piece, and then we'll take it over to questions. So this will be our last slide that we have here. Is if you're thinking about going into this program, I would definitely think about if you want to go alone with this program, or if you want to have a collaborative partner, having a third party like McKesson performing these services for you. That would be something that would be in the collaborative partner section. So your time to value with go alone is going to be much longer than having a collaborative partner go about this with you. The upfront costs are going to also be much higher if you're going alone with this, as opposed to collaborative partners. A lot of them will have some sort of an implementation fee that it'll be quite small, and then it'll be a per patient basis as what you would receive as a reimbursement on that. So there's skin in the game on both the collaborative partners part and also the client perspective. So it's one of those things that can really get you into that program. From a margin return on interest, or investment I should say, that there's greater control when you go alone, but it's a fixed margin when you have a collaborative partner. So if you're able to really control your costs, you can receive a larger margin when you're looking at the service, where with a collaborative partner, that's really going to be fixed. Provider staff time is going to be high when you're going alone because you're providing all of those resources. But with a collaborative partner, you're having low amount of staff time because you're having a nurse from that third party providing those services. You're having somebody create those care plans. They're taking a look at that technology. They're calling those patients. They're making the appointments. They're gathering all those records. So you're really just receiving the communication on how that patient is doing and receiving the records from those appointments. So you're receiving the benefits, but you're not having to put in as much money. You're not having to put in as much time with that collaborative partner section of it. One of the things that I did mention is that we do provide these services. So McKesson does have a nurse call center. We've been up with that since 2013. We've been providing these services since the beginning of chronic care management. If you were to take on this chronic care management program with McKesson, you'd be assigned a care team that would have nurses. It would also have a nursing support staff, so that would be the people that would be making the appointments for the patient and gathering the records from that care coordination perspective. And then lastly, we have a non-clinical staff, and that's our quality team. We're making sure that that quality of those phone calls and the experience that the patient is receiving is going to be exactly what you would expect from a McKesson product, that you're going to receive the best quality because we don't want that patient's health to be in the mix. Also, we look at this service as an extension of your organization. We do not identify ourselves as McKesson. We identify ourselves as your organization when we're calling on these patients. And we found that we've had a lot of success through the last year and 10 months providing these services to different organizations. So definitely, if you're looking to have a collaborative partner, we'd love to be your collaborative partner going through with chronic care management or any other type of nurse calling services when it comes to gap closure and helping out patients. With that, I will end that conversation. We'll start getting into questions here. So I really appreciate everybody jumping on the phone, being able to listen to this conversation. It's one that, even if it's not a great fit, if you don't have a lot of Medicare patients, it's something to definitely investigate because you've seen that that's where healthcare is going. They're going to this preventative model. The states are definitely going to get into this. Some of the states have already got into this from a Medicaid perspective, so it's something to definitely keep your ear to the ground on because it's going to potentially happen with all of the different payers. So if we could unmute the lines, or if we could go into some of the questions here. I'm not able to view if there are any questions or anything like that, but if there aren't any questions, I really appreciate everybody's time.
Bill, thank you so much. That was an excellent and very thorough and detailed presentation. We do have a couple questions that have come in throughout the presentation. A couple I was able to answer. Just as a reminder, as I had mentioned to start, if you do have a question, you could use the raise your hand feature in the program here, or type into the chat box and we'll get to your question that way. The first one we have here for you, Bill, is if a good portion of our patients are nonverbal, can the 20-minute care management conversation be with the caregiver rather than the patient and still be eligible for reimbursement?
Gotcha. That's a great question, and unfortunately those patients, I think we've just discovered a big gap in the service because the patient, it has to be a non-face-to-face call or service. So it can't be with the caregiver in front of the person. It actually has to be non-face-to-face. But if that person's nonverbal, if they have some sort of a way, maybe if it could be instant message or some sort of way that way, or text. I've even heard providers that have been providing this via text. That is another way that this could be done.
All right.
Or Skype. Skype would be a good way to do this as well if you have nonverbal.
Great, thank you, Bill. So as another reminder here, we are recording this presentation, so either later this afternoon or tomorrow morning, the presentation will be posted on our website, and there will be an email blast that includes the slides and a link to that presentation if you'd like to share this with colleagues or others at your health centers. Here's a follow-up to that question, Bill. It looks like many do not have the mental capacity and their caregiver is their only means of communication. So again, it kind of sounds like that may be a loophole right now to not fit the exact requirements.
And one of the things I should mention is that they can speak with the caregiver. So if they have a son or a daughter, or if they have a designated caregiver that they're working with, that is the person that we could also be on the phone. So I'm glad they asked that, the person asked that follow-up question, because that's one of the things that we do as well, is that we would talk to the caregiver and receive the services that way, or provide the services that way.
Great. Melanie, we can follow up with you directly afterwards as well. Thank you for that question. We have another one here from Natasha. Is there a standardized care plan that should be used? If so, where can we locate it? If not, what are the care plan components that are required, and where are the consent forms located?
It's a great question. I'm not aware if there is a generic care plan template out there or anything like that, but I can tell you what we use as our standard is that we first document all of the patient's chronic conditions. Then we use, it's more like a tree, if you can imagine that. So the chronic condition would be at the very, or an upside down tree, I should say. So that chronic condition is at the very top, and then what we have is goals that would be sprouting down from that chronic condition. From those goals, we would have any barriers that the patient would have that would not be able to meet those goals. And then lastly, we would have treatments that we would have attached to those different barriers so that that patient can overcome the barriers and go to those goals. So that's really what we have from a documentation perspective. Our documentation goes from left to right. So we would have the chronic condition, then we would have the goals, then we would have the, in different columns, we would have those items. So we would have the barriers, then we'd have the treatments.
Excellent, Natasha. I hope that helps answer your question. Again, we'll be sending this information out and contacting either us here at CPG or Bill McKesson directly for further information. You know, at any time is definitely a great way to get further questions that may come up answered. Looks like for the time being, Natasha, you do have a follow-up. You said, thank you. Is there a requirement on the frequency in which the plan needs to be completed?
Every time that patient is on the phone with the nurse, the care plan is reviewed. So the first conversation, that's very lengthy because you're creating that care plan from scratch. But after that patient has that care plan in place, it's just updates because you're monitoring how they're doing compared to their goals. So once a month is when that's being monitored and updated. Hopefully that makes sense.
Bill, thanks again. This was an excellent presentation, super detailed. I'm really glad you could join us here this morning. Looking forward to getting this blasted out to everyone as well.
Perfect. Appreciate everybody's time. Thank you, and CPG, thank you for having us participate with us.
Absolutely. I hope that you all have a great day, and we'll talk to you soon.
Thank you.
Bye-bye.